Good evening, everyone, and welcome to our session 8 of our Women's Health webinar series. My name is Helene, and I'm the Workforce Development Officer at Western Victoria PHN, and I will be a facilitator for this evening. Alongside me is Jade, who is our Workforce Development Officer also here at the PHN. I'd like to begin by acknowledging the traditional owners and custodians of the lands and waterways from which we are all zooming in from today. We recognise their diversity, resilience, and the ongoing place that First Peoples hold in our community. We pay our respects to the elders, both past and present, and we wish to extend that respect to any First Nations people connecting in today. We commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination for First Nations peoples and organisations, and we'll work together on closing the gap. Just a little bit of housekeeping. The majority of our webinar events are recorded and freely available on our PHN Learn YouTube channel. Jade will have that link up there at the moment. I have our upcoming events on the screen. You can register for these events on our website, and Jade will also put a link in the chat for you on that one. For this evening's webinar, could I ask all participants to remain on mute for the course of the meeting, and should you have any questions, type them in the message box and the question box there, and I will address them at question and answer time. They will all be addressed anonymously, so yeah, type away and we'll get those answered at the end. Also at the end of this session, we will hear from Dr. Tony Ma, who's the Gynaecology Director at Barwon Health, and he's going to give a brief overview and update for the Barwon Gynaecology unit with some questions at the end. But I'd like to take this opportunity now to introduce our speaker for this evening, Dr. Payan Nikpoor, and he's a urogynaecologist and pelvic reconstruction surgeon. Thanks, Payan. I'll now hand over to you.
Thank you, Helene, and thank you, Jade, and to all of you giving up your Wednesday night coming to the meeting. So I'm going to present to you pelvic organ prolapse. A topic, of course, is part of my keen interest, and I'm going to go about a bit of a basics about understanding what it is, how it happens, and what are the management options. It's something that would come up in every GP practice, wherever you work in the world. Doesn't matter really, it doesn't have any borders. So, and of course, questions, I'm very happy to address the questions at the end. So if anything, by all means, just type it in and we will go through them. So going through some learning objectives. So I want you to kind of, as a take-home message, have an understanding of the pathophysiology and the presenting problem. And of course, the management options, which generally either conservative or surgical. Pelvic organ prolapse is a very common condition. It does happen to a wide range of women in the community. We know that in a lifetime risk, there's about 7% risk of surgery needing, like a woman needing surgery for pelvic organ prolapse, and just over 10% by the age of 80 years will have surgery for pelvic organ prolapse or urinary incontinence. One issue that is always a challenge as an ongoing, both for the practitioners and for the patients, is the repeat surgery for recurrences. And it can be as high as 30%, with majority happening in the same compartment where the surgery, the index surgery ever happened. So this is a dynamic thing, and I always make this analogy to my patients that, you know, if you go and have a cholecystectomy, gallbladder removed, you will never grow back any gallbladder. Or if you have a hysterectomy, you will never grow back a uterus. Whereas in urinary incontinence and prolapse, there's no way that you can go and address it indefinitely. You can go and fix things, rearrange things, reconstruct it, but there is the process of aging and ongoing dynamic tissue changes that would bring on the challenge of recurrences and the surgery's effect, of course, diminishing over time. So moving on from there, there are some risk factors that is very important. I think this is important. Risk factors are important because we can identify the modifiable and non-modifiable risk factors. There are things like age, for example. You know, you can't modify age. We always get older. We never get younger, unfortunately. But obesity itself is a risk factor that can be modified. So there are options about weight loss, weight management that can be addressed. And even it can start at the level of a GP practice. Pregnancy and childbirth, again, is a risk factor that is kind of non-modifiable in the way that if you see a woman at the age of 60, 65, 70 who is presenting with these problems, all these incidents have happened several decades in the past. So whatever has happened, so you have to deal with it right now. But there are more talks now about the informed consent about the vaginal delivery and how it can affect the pelvic floor and pelvic floor dysfunction in the long run, which is beyond the scope of this talk, of course. But as we know, the parity is an important risk factor. The higher the number of the childbirths, the higher the risk. And of course, the vaginal delivery, in amongst them, forceps, followed by vacuum, which are our instrumental deliveries. And between forceps and vacuum, forceps is the most traumatic one. And as the index risk is your vaginal delivery just by itself. These are kind of like the associated risk factors in terms of pregnancy and childbirth that need to be taken into consideration. Chronic raised intra-abdominal pressure, such as chronic obstructive airway disease, asthma, smoker's cough, constipation, all those kind of things. These are, again, modifiable things. These are manageable conditions. Family history, again, 2 to 3-fold increase in the risk. We don't exactly know what gene it is. We haven't found it yet, but we know that there is an association. And usually women who present with prolapse will give you a history that my mom and sister or my grandma on the maternal side had the same problem. Of course, hereditary or acquired collagen defect conditions, especially type 1 defect, is a risk factor. And previous gynecological surgery, of course, is a risk factor. Each different type of surgery imposes different types of risks, of course. But again, this is something more important for documentation in the history and finding out what can be modified and what kind of risks are imposing the presence of the symptoms. Factors that have not been identified as a risk factor include smoking. Smoking itself. Just because you smoke, we know that we can get lung cancer, for example, but by smoking, you don't get prolapse. But indirectly, if it causes a smoker's cough and leading to increased rates intra-abdominal pressure, that's a risk factor. Menopause itself, the jury is still out. We don't really have a conclusive evidence that menopause just by itself would impose risk as a menopause. But it does definitely change features and characteristics in the connective tissue that can maybe predispose to pelvic organ prolapse. Ethnicity doesn't, physical activity itself doesn't. We're talking about just general physical activity. We know that in very high impact athletes or those people who do high impact manual handling, it is actually a risk factor. Just by being physically active person, going to the gym and doing all those things, it's not. Same as diabetes mellitus and hypertension are deemed not to be a risk factor just by themselves. Symptoms of prolapse, of course, this can present with different types of symptoms. Usually symptoms could be vague and may not necessarily correlate with the severity of the symptoms. Some people may not necessarily have any sensation of the prolapse, but when you examine them, you clearly could see the bulge. And in some people, there might be actually feeling of heaviness, dragging sensation, etc. Whereas when you examine them, you don't see as severe prolapse as you would expect. But symptoms usually in the way of vaginal lump or protrusion, pelvic pressure, heaviness, low back pain in some cases, feeling of something coming down or out of the vagina, or vaginal flatulence as in passing wind through the vagina. It's also another risk factor. It could also be affecting the other organs around the vagina, which is the bladder or the bowel, of course, so you can present with urinary symptoms, such as different types of incontinence or retention or voiding problems, or it could be the bowel problems on the other hand. And I've got some pictures that I'm going to show you so you will have a better understanding out of this. And of course, the prolapse can affect sexual function in itself, which is usually vaginal laxity, dryness, dyspareunia, friction, all those symptoms that people might have a complaint about. Some people may present with vaginal discharge or bleeding, mainly because of the ulceration in especially advanced pelvic organ prolapse cases. Now, this is my own drawing. Okay, I really sat down with a pencil and a paper. I've drawn this. I hope you don't mind the very simplistic approach. But if this is the abdominal wall at the front, then you've got the bladder. Then you've got the urethra, then you've got the vagina here, and the uterus, tubes, and ovaries, as creative I could have been with my drawings. And then we've got the anus, anal sphincter complex, and the rectum at the back, and this is the sacrum. So if we draw a line here, you've got anterior compartment. In the middle one, we call it apical compartment, and the back one, we call it posterior compartment. So in your anterior compartment, your sort of like organ is your bladder and of course the urethra. In the midline or in the apical compartment, we look at the top of the vagina itself, which is the cervix. And if you have had a previous hysterectomy, this becomes the vault basically, which is the vaginal cuff as we refer to it. And then the posterior compartment, you've got the rectum and of course the anal sphincter complex. So it goes without saying that in the anterior compartment prolapse, you're going to get a cystocoele or a urethrocoele. Whereas in the vaginal compartment, in the middle compartment, apical compartment, you will get uterine prolapse. And in the posterior compartment, we get a rectal, sort of like rectocoele, we call it, or a posterior compartment prolapse. So these are the kind of like, it's a visual understanding of what is what and where things are located. And you may rarely see someone with a single compartment prolapse. It's most often it's a multi-compartment prolapse. It's very unusual for someone to just come in with a bladder prolapse. There's usually a combination of these compartments together. So moving on from here, so as I said, could be apical, could be anterior vaginal prolapse, or could be a posterior vaginal wall prolapse. And I'm going to show you pictures of this now. Just again, I would like to mention there would be pictures coming. There are real pictures of my own patients. So if you've got little kids around, if they're not in sleep, I would just like to warn you that some of those pictures are pictures of real patients. So you may want to ask them to leave the room if you can. Pathogenesis for prolapse. So what causes the prolapse at the heart of it? It's the damage to the levator ani. So there's the levator muscles, which is the muscles that cover the pelvic floor at the very bottom part of the pelvis. And most often it's an obstetric trauma that has caused this problem, followed by decreased muscle tone and strength. It's atrophy and aging that does cause that. And of course, a widened genital hiatus, especially this happens with a vaginal delivery. Each time with stretch and tear that happens to the levator muscles, the opening of the vagina, what you would see is basically like on the external examination, but the actual levator muscle that is supposed to hold it, it distends and makes the hiatus much larger. In the levator muscles at the very bottom of the pelvis, in the female, we do have a natural opening, which would be passage of the vagina, and that's where the baby passes through during childbirth. So this has to distend and open up to allow the delivery of the head, shoulders, and the rest of the body. And that, of course, in the long run is basically what causes the problems too. And unopposed intra-abdominal pressure on tissues, which is again your chronic cough, constipation, significant manual handling, very heavy, strenuous activity. And of course, the connective tissue stretches over time or connective tissue disorders is also another condition that would contribute to this condition, okay? So pictures are coming up. This is again, a little drawing here. This is a real patient. So if in this case, bladder, uterus, rectum, and if the uterus drops down and comes out of the vagina, in this one, what I'm holding with my right hand is the cervix that has descended, as you can see, about 4 or 5 centimeters outside, And what I'm holding here is actually the bladder that has been coming out completely with the prolapse in itself. So this bulge is composed of cervix, which is the uterus right immediately behind it, and the bladder, which is sort of following that. This is another condition that, you know, the whole thing is starting to come out. This is a stage 4 prolapse, where the whole uterus and the cervix is completely outside. And this is, as you can see, this is the cervix opening, and this whole thing, which is in measurement, it was around 12 centimeters, completely outside of the vagina again. This is called procedentia or proxidentia, and is a stage 4 pelvic organ prolapse, the advanced stage. We've got stage 1, 2, 3, and 4. So this is like the most advanced one, of course. This is another one when a woman does not have a uterus and the vault, the top of the vagina, starts to descend and come down. And in this case, we've got complete version. So the whole vagina is completely outside. So as you said, the urinary catheter goes in here, but actually the bladder is right here, part of the rectum is here, and this is the vaginal vault, which is completely inside out. This is a cystocoele, as you see, in the anterior compartment. So this whole thing is actually the bladder that is bulging outside of the genital hiatus, or the introitus in this case, as you can refer to anatomically. So these can present itself with different types of symptoms: voiding difficulty. Of course, this causes a reservoir for the urine not to be coming out because of the angulation. Imagine when you sit on the toilet stool, this would be below the level of the urethra. So whatever urine is accumulated here is not going to be able to drain properly. So because of incomplete bladder emptying, these people can have overactive bladder, several trips to the toilet trying to empty the bladder. This could affect the continence, in terms of urgency, stress incontinence, urge incontinence. Majority of the urinary symptoms can easily be explained with these pelvic organ prolapse ones, or in some cases it might be a different condition related to the bladder function in itself. So this is another one, urethrocoele. I don't have a real patient picture of this, but this is when with the distal part of the, the proximal part of the urethra starts to dilate and descend, and this condition happens here is the urethrocoele, or the urethral prolapse, is the time that this part is starting to descend down. Now, again, as I said, it's almost impossible, like very rare, that you would see someone coming in with just one single compartment prolapse. The majority of the times they're associated with one another, and it's just something that would come up and would be evident on examination. Rectocoele, this is the posterior compartment prolapse. So as you can see, this is the anterior, this is where the urinary catheter goes in. I've got hooks to create retraction, and this is the rectum that is bulging through the vagina. So imagine if you've got that again, as you strain to open bowels, this will be another reservoir or a false space where the feces can get trapped here. So feeling of incomplete evacuation, difficulty passing, or needing to go back to toilet immediately after passing stools are the very common symptoms that people can present with these ones. Again, enterocoele, again, it's a condition that I guess I'm putting the picture on so you get familiar with it. It's really you need to have experience in examining these cases to find out. It's usually the descent of the small intestine through the pouch of Douglas posteriorly, so the space between the uterus and the rectum, where there's weakness in this pouch normally, and then it starts to protrude down, will present itself with a bulge in the posterior compartment. But when you examine these ones, you actually find out the bulge is further high, and it's just descending further down and down into the vagina. This can present with, again, bulge, pressure, heaviness sensation, or bowel strangulation, or people presenting with bowel obstruction even. So the approach is really take a history. I guess history is very important because you want to find out what kind of symptoms are really bothering your patient. Everything falling out, something, the words that people use. Vaginal bulge is a very common symptom, something bulging. I feel a lump, I feel pressure, I feel there is some, I'm sitting on a kiwi, I'm sitting on an orange, I'm sitting on a golf ball. People, how they explain this. Some people present with low back pain, especially retroverted uterus pulling down can put pressure on the lower back and present itself with lower back in people with pelvic organ prolapse. Difficulty or pain or embarrassment with intercourse is another, of course, the sexual dysfunction side of things related to pelvic organ prolapse. It can present with urinary incontinence or fecal incontinence due to how those anatomical defect, as you saw, that can happen. Voiding difficulty, as in needing to sort of position themselves, change position, stand up and sit down, sometimes holding fingers to push the prolapse in to be able to pass urine, or difficulty emptying their bladder and incomplete bladder emptying, all those symptoms that they can present, or sometimes the defecatory dysfunction, as we talked about it. Always ask about the sexual activity. How does the prolapse affect it? Majority of the times people say that, you know, it's I'm actually embarrassed to have sex. This is going to cause, and the fear of this can cause problems and issues. Always take an obstetric history. You want to find out what would have been those risk factors in your history that would have contributed to this. It's again good for documentation and just making you clear on the assessment of the prolapse. So again, medical history, as we talked about this, and social history, employment. Reason I say this, I remember I had a patient who had pelvic organ prolapse, and I didn't ask what was her job. So she came in, she had a big prolapse. We came in, had a hysterectomy, suspension, repair, everything went well, really good surgery. She was in early 50s. And then she came back in 6 weeks visit. She was all good and all fine. And then she wanted to go back to work. Again, I didn't ask, what kind of work do you do? She went to work, and then about 4 months time, 4 or 5 months time, she came back with a recurrence vaginal. And why? This is unusual. Doesn't happen like this. And I actually asked her, what do you do for a living? So she was working at the back of Bunnings, moving very heavy pallets of goods and stuff when they come in. I was like, this can't continue, you know, this is really important, you know. Work is important, and I guess it is something that needs to be taken into consideration when you take a history. Pelvic organ prolapse, I don't want you to learn this. I've put this out so that you just see that sometimes you see people talk about something called POP-Q, pelvic organ prolapse quantification system, POP-Q system. So this is actually a systematic way of measuring the prolapse. And we actually do this in our unit, all pelvic floor units or urogynae units. We are very sort of religious about this. All of our measurements are documented by this. So this has shown a very great deal of inter-observer and intra-observer reliability. It's very good for documentation, follow-up, effect of the surgery, and in terms of wanting to hand over to another colleague. So if you send me something like this, if I read the numbers, I can actually, in my head, I can work out what's the prolapse, what's the major compartment, where it's affected. It basically refers to certain points in the vagina where we do our measurement and how far they can move down and up in the vagina. So it would give us an indication of the severity and degree of the prolapse. But basically, based on that, again, based on those measurements, we usually have got these stages of prolapse. Stage 0 is the time that you don't really have any prolapse, sorry. Stage 1 is whatever is you've got in the very upper portion of the vagina. So this is your stage 1 and descending to almost halfway through the vagina. But when things start to descend further down, it's your stage 2. Stage 2, it's very important, as if you get your hymenal remnants, see this says hymenal remnants, anything that moves within a centimeter above or below the leading point of prolapse, if something comes 1 centimeter above the hymen or that level of the hymen, or 1 centimeter below hymen, like protrudes only 1 centimeter, that's stage 2. Anything that comes outside of that, more than 1 centimeter, we call it stage 3, but generally these are reducible ones. And stage 4 is when completely outside and the leading edge of the prolapse is more than the total vaginal length, which means that your vagina is inside out. That very big prolapse picture that I showed you in the very beginning. Again, I don't really want you to be too fussed about this, but I want you to know when we talk about this, what they are. The most common stage that you see in your practice will be stage 2 or stage 3, majority of the cases. Moving on, management of prolapse. How we want to manage prolapse, it's really guided by the severity of the symptoms. We want to do urodynamic studies to assess urinary symptoms if present, and of course, imaging of the pelvis if suspected or advanced prolapse has been seen. Again, we've got 3 options. Do nothing, conservative surgery. I don't know, some of you might be wanting to sit the exams, RACGP exams, FRANSCOG exams, and this do nothing conservative surgery, which I've written here, is an exam answer kind of thing. You know, the 3 options. You will never die if you don't do anything with your prolapse. But to me, do nothing is not an option. You can't possibly see a bulge in a woman who has come to see you, is paying you a fee for visit, paying me to see me, and I see this big bulge and I say, okay, one option is do nothing. No, that doesn't work. In real life, in everyday practice, we can never tell anybody do nothing. I never tell anybody do nothing. It's the patient's choice not to take actions, but it's not my recommendation to do nothing. As a minimum, conservative management. We need to modify the lifestyle, weight loss, quit smoking, manage medical conditions, pelvic floor exercises, physiotherapy, all those sort of things that can be done, which is your conservative management. But again, historically, conventionally, we've got this do nothing thing, which has gone into the answers, unfortunately. And I've just written that there, but I do not concur. Conservative management of prolapse you need to modify risk factors, lifestyle, you need to consider pelvic floor muscle training and exercises. Vaginal estrogen, especially for postmenopausal women, it would be a very good idea, and use of vaginal pessaries, which I've got a couple of slides to talk about that, and it's very important. So this basically is the foundation of your conservative management, really, that you take into consideration. So what do we know about the prolapse and pelvic floor muscle exercises and pelvic organ prolapse? And those of you who are interested, these are the references, and of course these will be available for you later on if you wanted to go and read these ones. I know that most of you can be very busy and not have time to go through these big papers, but if in case you were interested, these are landmark trials on the management of prolapse with or the role of physio in management of pelvic organ prolapse. But the conclusion of those studies and Cochrane reviews, etc., is that pelvic floor muscle exercises versus no active treatment, like that do nothing kind of thing, okay? Pelvic floor muscle exercises is effective in reducing the pelvic floor symptoms in women with prolapse, is effective in alleviating specific prolapse symptoms, especially the bulge, but it's not effective in reducing the prolapse severity on POP-Q. So it doesn't make your prolapse go backward, but because you strengthen your muscles and the tone and coordination of pelvic floor muscles improve, your sensation of prolapse improves. The bulge feels to be smaller. And because it's basically because you've got a good grip, you've got a good muscle in the pelvic floor. Pelvic floor muscle versus surgery. So of course, it does not improve the prolapse or stage of prolapse compared to those people who are going to undergo surgery for pelvic organ prolapse. There's a trial called Optimal trial, and this is a one that was a study as a randomized trial, one of the biggest studies published ever. Again, I've included this for those interested, but what I'm going to say about this study is that it's a study that compared 2 types of surgeries for management of prolapse, which essentially showed that these 2 surgeries, including uterosacral ligament suspension versus sacrospinous fixation, which I'm going to show you pictures of it, they do not differ in effectiveness. But what they did in their case was that a group of these patients were allocated to do physio and then do surgery, and a group went directly not doing any physio and then went ahead and had one of these two surgeries. The long-term outcome out of this study in the 6 months follow-up, 2-year follow-up, and 5-year follow-up was shown that the two studies were not statistically significantly different in the effectiveness, and those women who had physio before surgery did not have a better outcome compared to those women who directly went on and have surgery. Meaning that if someone really is in need of surgery, it's better to have surgery and then have physio later on for an ongoing maintenance for enhancement of their pelvic floor function. This is probably the largest ever RCT published in the history of gynecology who have assessed this question. And we are very privileged actually to have this. We didn't really have all of this some years ago. This is relatively recent. Vaginal surgeries again, vaginal pessaries, you know, I'll put a picture here. Some of these I haven't even seen myself really. I haven't even held some of these ones, especially like these big ones at the top. The ones that I use most often is a ring and these Gellhorn pessaries, okay? So now a ring can come with this little thing in the middle. We call it ring with support. Or this one is like a little dish, basically. Or some of them have got this little knob. So that's a ring with a knob, as simple as it. And this goes without saying, you know all what it looks like a donut, okay? So that's a donut pessary. So you've got a ring pessary, Gellhorn pessary, donut pessary, or this is a cube. It looks like a cube, so we call it cube. No, as simple as that. So there still remain a mode of treatment for prolapse and also incontinence, especially the ones with the knob are the ones that are used for stress urinary incontinence. They're made of silicone and some of them are latex. They come in various shapes and sizes, goes without saying again. We've got 3 types basically. One of them is the support ones, which is generally either this ring or the dish or the ring with support or that one or this one. So these ones are the ones that we call them support. There are other ones that are space occupying, so donut, Gellhorn, cube, you know, these ones are space occupying. And incontinence ones are the ones, as I said, the ones that have got a knob with them. Again, for your understanding to know, and can be used in pregnancy also. They're safe in pregnancy. Usually we use a ring in pregnancy. Cubes also have been used in pregnancy, as well as some donuts, smaller sizes donuts. So after fitting, we ask the patient to bend and move and, you know, make sure that she's able to pass urine and she's comfortable. And they use topical estrogen, especially for postmenopausal women. We don't necessarily need that for premenopausal women. There's a low discontinuation within first months of fitting. Excuse me. Teach the patient how to insert and remove. This is, of course, for those people who are younger, more dexterous. If you've got an old lady who's sort of got arthritis, joint deformity, it's not easy for them, or obese women may not be able to manage that. We usually review them in the first few weeks after insertion, and then as an ongoing every 4 to 6 months for a review. Some disadvantages with pessaries is that they almost always they cause discharge because it's a foreign body. Some of the risks include infection and erosion, which can happen in around 5% of cases or less than 5%. And in rare cases, I've seen only one ever in my career coming in with a fistula for a pessary that was inserted and was neglected and forgotten and no follow-up and all those things. And there was a rectovaginal fistula out of this that happened for that lady. This is again in a recumbent position, how the pessaries sit inside the vagina relative to the uterus vagina. How does it sit? Again, as a visual understanding for you, so you can actually understand. You can only teach the patient to remove a ring or a dish, for example. The big ones like the donut or cube or the Gellhorn ones generally needs to be removed by a specialist or a continence nurse or a physiotherapist. Pessaries fail because incorrect size has been used. It's like too small, that they fall out. Incorrect choice of a pessary, especially for advanced prolapse. You need a space occupying one. A ring usually falls out. And of course, a widened genital hiatus is another risk factor. Levator avulsion that does happen through childbirth is also a risk factor for the pessaries to fail. And of course, a short vagina. Vagina that is less than 6 centimeters is a risk factor for failure. So I'm going to quickly now go through the surgical options. So we've got 3 goals in surgery. We do surgery once the conservative management fails. Just because someone has prolapse, it doesn't mean that they have to have surgery. Of course, it's patient choice, but physiotherapy is perfectly safe. Pelvic organ prolapse can be managed with physio, and if someone chooses to go through physio, fine. Maybe not for the one that everything was hanging out, as you saw. That probably goes without saying surgery is necessary for those ones. Even though we've had old patients that we've used a very large Gellhorn to insert and try to manage it. So these are the goals. You want to restore the anatomy, relieve symptoms, maintain or restore bowel and bladder function, and maintain vaginal capacity for sexual function. So that's the goals of your reconstructive surgery. It became available some centuries ago, of course. When you want to consider surgery, we do consider different things, whether we should go vaginally or we should go abdominally. In the abdomen, you can go by laparotomy, you can go by laparoscopy, you can use robotic surgery. Whether you should remove or preserve uterus, whether you do hysterectomy or you do hysteropexy, whether it's a primary surgery, you're the first surgeon going and doing it, or someone has done a surgery before and she's coming back with a recurrence. Recurrence prolapse always has got a poorer prognosis on surgery compared to the index surgery. Whether someone is sexually active, wants to maintain sexual function or not, whether you need to do an incontinence surgery at the same time, or should it be cancelled about 2 separate surgeries, whether you want to use reinforcement material such as mesh or biological materials, which are not really available these days, but I have included that in our comments here. The name of the surgeries that you will hear in discharge summaries or letters coming from the gynecological surgeons include in the anterior compartment, you might hear anterior repair, fascial plication, site-specific repair, paravaginal repair. These all basically are native tissue repairs in which a combination of absorbable sutures have been used to fix the fascia, and I've got pictures to show you so you can understand what they are. In the apical compartment, with or without uterus present, surgeries can include the sacrospinous surgery or a hysteropexy. Sacrospinous colpopexy is when you don't have a uterus and you want to fix the top of the vagina to the sacrospinous ligament, or if you've got a uterus and you want to fix the uterus to the sacrospinous ligament. So sacrospinous is a ligament at the back posterior aspect of the pelvis, both in men and women. Uterosacral ligament suspension is also another option. And then sacrocolpopexy is, sacro is sacrum, colpo is vagina, pexy means fixation. So it's actually fixation of the vagina to the sacrum bone. Sacrohysteropexy is fixation of the hystero, which is the uterus, to the sacrum bone. This operation is done abdominally, either by laparoscope, laparotomy, or by robotic surgery. Manchester repair, I won't go through the details of that, but it's basically an amputation of the cervix that we do, is a vaginal surgery. Posterior compartment, again, very similar to anterior compartment, fascial plication, all those kind of things that can happen. And of course, the obliterative surgery, where you close the whole vagina, you sew it up. It's called colpocleisis or Lefort surgery, that I will show you pictures of that too. So this is the anterior repair. We've opened the anterior vaginal wall. This is the uterine cervix, and right above that is this is like behind this layer is the bladder. This is the fascia. We're trying to dissect, free it up, and just plicating it. You press this and bring together, plicate, and then bring layers together, and you put stitches. So you pull from side to side, put a stitch, pull from that side to that side, stitch. So that's your midline plication. And these are generally dissolvable stitches. Some people use permanent stitches. Don't ask me why, but the evidence is generally not different. So what we rely on is that fibrosis that happens where you've done the surgery. That again, as I mentioned, is a dynamic thing, and there are tissue changes as we go on. Cochrane review just mentions that the native tissue repair versus biological graft, no difference in the awareness of prolapse or repeat surgery for prolapse or dyspareunia or SUI. Native tissue repair results in more recurrence of prolapse. As opposed to using a biological graft, we can use a synthetic mesh, a native tissue repair, which is using patient's own tissue, same as the last picture that I showed you. So transvaginal mesh is better in terms of its actually recurrence of prolapse as well as symptomatic prolapse. But the problem is that mesh can cause problems. And so transvaginal mesh is something that can create mesh-related complications. And as of now, the current evidence says that because of the comorbidities arising from that, there is no benefit that would be using mesh in the management of pelvic organ prolapse as opposed to the native tissue repair. But these data, again, based on older study where we had a heavier meshes, now the light meshes not really available, but they're available. It can be done. Again, it's a subject to research that we should be watching that landscape in the next years to come. Absorbable mesh never really took off, and there is not enough evidence for that. Posterior repair, again, like an incision is done here, the fascia is brought together, midline plication, as you see that is happening, and then the vaginal wall that we opened in the beginning is closed here along that with stitches. So again, with the posterior compartment, it can be done vaginally or transanally, and transanal approach is inferior to the transvaginal approach, and it's got proven benefits that it's better be done through a transvaginal approach rather than a transanal approach. The current evidence does not support the use of transvaginal mesh for posterior compartment. Then we've got the options of managing the vault or the top of the vagina, and the way that it can be done is by different types of surgeries, okay? So I'm going to go through this step by step again. Sacrospinous ligament, so that's the sacrum bone, that's the pelvic bone, and as you see, this is the sacrospinous ligament. What we've done here, we've attached the vagina. The vagina is attached to the sacrospinous ligament by these stitches here. This is called sacrospinous colpopexy, which we are attaching the vagina to this. So imagine if there was a uterus attached to this, we were attaching the uterus to this. In the times that uterus drops and comes down, it can be attached to the sacrospinous ligament. So it's called the sacrospinous hystropexy. Again, we've got another ligament that is going from the side of the pelvis towards the sacrum bone. See, look at that. It's another direction. This is called the uterosacral ligament. And the vagina can be attached to the uterosacral ligament, as you see right here. That's the vagina, that's the bladder, that's the rectum at the back, rectum here, rectum at the back, rectum. So the vagina is attached to the uterosacral ligament on each side for elevation and supporting of the vagina. Again, mesh products or grafts that can be used are either biological or synthetic. Synthetic are the meshes that were subject to significant scrutiny and still continuing, and we don't really have any more meshes available to perform pelvic organ prolapse surgery. The only mesh available right now is for us to use for mid-urethral slings, which is the beyond scope of this talk, of course. Some mesh kits that were available before and different types that came into the market, and I'm going to show you some pictures. This is a sacrocolpopexy. If you've heard or seen that in discharge summaries or letters, that's the vagina. This is the mesh in a Y-shaped mesh. Remember, I showed you these ones, these pictures. It's like a anterior and posterior leaf and a tail here. So we place one leaf on the front, one leaf on the back, and the tail is attached to the anterior longitudinal ligament on the sacrum bone. So this is a sacrocolpopexy, so attaching the vagina to the sacrum bone. Again, vaginal surgeries to address the top of the vagina, the vault, compared to sacrocolpopexy, which is an abdominal surgery. Sacrocolpopexy outperforms it. So it's a better option in terms of duration and longevity. But unfortunately, all the companies that were making the mesh for us to perform the sacrocolpopexy have closed down now. So at the moment, we're not doing this surgery as much, and there are newer variations coming in that we are doing studies on this. But again, this is a summary of the evidence in support of the sacrocolpopexy over vaginal surgeries. Complications, well, there are some intraoperative complications that we generally deal with it, but post-op can be de novo urinary incontinence, de novo voiding dysfunction, sexual dysfunction that can arise, and it can continue to become mesh complications such as mesh erosion, exposure, either vaginally or in the bladder or in the rectum or in the ureter, can cause pain, dyspareunia. Dyspareunia is when the partner complains when they're having sexual intercourse and generally complaining of friction, something sticky or something very sharp and cutting me, doing this, doing that, those kind of complaints. Linda Brubaker, one of the international urogynecologists who works out of United States, first coined this this terminology, dyspareunia, as opposed to dyspareunia for a woman. Colpocleisis, I'm going to quickly talk about this. Is an operative surgery where we close the vagina, and I've got pictures for this. This is my patient again, uterus completely outside. So this is the anterior compartment. See, like that's the bladder bulging, that's the posterior compartment, and this uterine cervix is completely outside. We take a layer of the skin from the front, a layer of the skin from the back, and we start to suture back to front in an inverted manner. And as we continue doing this, we just gently, slowly push this in. And as you see, the whole bulge has disappeared. And we make the genital hiatus smaller by a perineoplasty. And this woman will never have a vagina again. That's the most important thing, that they need to be sure that sexual function is not going to be something they desire. Generally, it's for older patients. This woman was 93-year-old from nursing home. So she was like absolutely happy to have this. 2 years I've done this surgery, she hasn't come back, so I'm very happy that she's enjoying her life. I hope so. But this is like colpocleisis, and this is how it works. Contraindications, again, this is more scientific matter that I have left here for you to read later on in your reading when these slides become available to you. The scrutiny about mesh, it was everywhere, started a few years ago. So mesh became a bit of an issue and problem because of all the different complications that can happen with it, as in erosion, extrusion, mesh infections, as in abscess, sinus, wound infection, breakdown, pain, urinary symptoms, fistula formation, recurrence of prolapse, and all those issues and problems that were affecting women. So what is available in Australia now? So all transvaginal meshes, like as a mesh kit to fix the prolapse, gone completely. Abdominal mesh sacrocolpopexy last year was available. It's not available anymore. That's stopped. The only thing we've got is the mid-urethral slings to perform stress incontinence surgeries, and that's still TGA approved, so we can use that, and we are using it. Single incision slings need to be only used in a randomized controlled trial. And this is my last slide, worthwhile reading. There are some links on this that you can click to sort of like read. Good for your knowledge again. These are especially the NICE guidelines. I think it's a good resource for the exam if any of you sitting exam at any point in time. And I've got few tools for health practitioners developed by Gene Hales, of course. So these are all the things that you're welcome to download free from Gene Hales' website. And I think that's the end of my talk.
Thank you, Payan. I do have a question that's coming.
Yep.
Why do you need topical estrogen in postmenopausal women when using pessaries?
Yeah, so as a very common condition in a postmenopausal women, you do have vaginal atrophy. So the rugae in the vagina are almost non-existent. The vagina, instead of having the rugae, those little sort of ridges inside, becomes a very flat, thin layer. Placing a pessary in an atrophic vagina leads to a risk of vaginal erosion. So where the pessary is sitting, it can actually rub or scratch the lining and lead to vaginal erosion that leads to bleeding and infection. So by using a vaginal estrogen, you mitigate that risk. You don't eliminate it, but you reduce it significantly. That's the main indication that we use for.
Okay, there's no more questions at this stage. If you do have any questions, quickly pop them in there because we do have a few minutes for Payan to answer those. Just take this opportunity to thank you so much, Payan. That was so good. That was an excellent talk, and there's really fantastic comments coming in from your talk, which I will share with you on your email later. That was excellent, really good. So I'll go straight on to Tony Ma now. We'll pop him on, and if there's any questions coming in the meantime, I will get Payan to answer those as well. So
Absolutely.
over to you, Tony.
Hi. Hopefully I have now shared my screen.
Yes, you have.
Excellent. Thanks all for sticking around at the end. It's just a very quick add, if nothing else, an update for the Barwon Health Gynae department. My name's Tony Ma, I'm the Gynae director, and just an introduction to our team, just so if you're ever speaking to them by phone, you have at least seen them on the internet. This is Beck Murnane. She's a Gynae outpatient clinic coordinator and does a lot of the phone call returns. And she also does all our triage in conjunction with myself. And these are our two theatre bookings ladies, nurses, Sarah and Courtney. So just a few faces to names. The reason why I wanted to have a talk to you all is we desperately need new referrals. We are in this enviable position of actually having no wait list in gynae clinic now due to some changes which I'd like to bring up to explain to you all. So basically we used to be an outpatient pre-admission service only until 2017. Patients were seen in private rooms, and then if they needed an operation they were sent to Barwon pre-admissions clinic, and then they went off for surgery. From 2017 patients could be seen at private rooms, and they had about 200 people on that wait list, and they're waiting 3 years to then be sent to pre-admissions clinic. And then there were about 150 people waiting for surgery that was captured by the government wait time. So we looked really good, even though you're waiting 3 years off the books. Public gynae clinic also, as many of you would have known from many years ago, there was up to a 3-year wait time and over 1,000 patients waiting before they came to pre-admissions. Oh, and then they were seen, and if they needed surgery after that 3-year wait, then they were then put into this system of pre-admissions clinic. They're still not on the books, and that could be up to 2 years. And there were about 60 people there. And then there was a documented wait time. So again, we looked much better than we really were. Since more recently though, and in fact, just in 2021, that slide's incorrect. What we've done is we've tried to streamline things. So private practitioners can just get on with consenting minors on Barwon Health public paperwork, and they go straight to theatre, so they're on the books. Gynae may just come to pre-admissions clinic, but there's a much shorter wait, because also in public gynae clinic, we now have getting on and going to be consented. And so these are all captured within the system. So we've got rid of this invisible wait time. There's no pre-admissions clinic where you see one of the 3 consultants and then come back another day to see your primary surgeon. So the flow is more efficient. The person who sees your clinic will be the person who operates on the patient. So there's continuity there. There's better teaching for our juniors. Everyone who operates is also consulting an equal amount. And we can actually stratify patients from your referrals to the appropriate consultant most of the time. And everyone is triaged or timed to surgery from the time they're referred by the GP to the gynaecologist. So it doesn't matter if you're public or private, your wait time to surgery is off when the GP referral was made. So this means that then the public patients, or the people who go to Barwon public surgery, aren't advantaged or shortcutting by going to see private consultants. So we're trying to build in equity for all. And this is what I just wanted to show you is in 2015, you could see we were getting about 200 referrals a month, and then more recently up to 300. You could see this is our wait time, just our total waiting patients blowing up to the heady heights of 1,000 plus. And then so you can see basically once we started this new clinic system, even though the gynae clinic referrals were continuing to increase, our total wait time plummeted from over 1,000 down to about 400. So as of most recent check, we're down to 340. So basically, I've got about 6 weeks worth of gynae patients before I run out. And if that happens, then they're not going to continue to allow my clinics to run. So not only have we increased the efficiency, we've increased the numbers of gynae clinics that we run. We used to only see about 30 to 60 gynae clinic patients a week. Now we're seeing about 130. And we've increased our operating sessions from about 8 to 16 post-COVID. So basically, your wait time for a gynae review is 6 weeks in Barwon region at the moment, whereas to see me privately is probably in the order of about 3 months. So these are the other things we've made. Phone consults, which has meant that no one's getting parking fines, waiting 3 hours just for a 10-minute results. Increased gynae clinics Wednesdays and Thursdays, giving patients more options. Active involvement of triage. Many of you have probably got my letters back just asking for more information, or often sorting things out just with the letter when patients aren't required to see us. We've merged public and private waitlist. We've increased our VMO staffing. We've streamlined the procedure. We've got more operating. So you can see our surgical waitlist was going great. We basically managed to get down to 74 patients waiting for surgery from a height of several hundred. And remember, there was lots of people off the books. And then co-brand happened, and now we're up to 300 and something. But from August, we've been told we're going to be full theatre staffing again, and we hope to drop that relatively quickly again. So you can see as of May, once you're seen at gynae clinic, a category 1 patient's operated within 2 weeks, a category 2 within 6 months, and a category 3 within the year. So we're actually hitting our targets now instead of what we had before. You can see wait times in terms of people who were getting overdue on the category wait list blew right out when we weren't keeping up. Then we opened building B, and with this increased gynae clinic service and streamlining, we were able to get right down to less, or just 6% of people running over their category waiting time, which is excellent. So you can see we've gone from 30 patients per week to 130 patients per week. We now have a public colposcopy service. So I think one of the great injustices prior to a few years ago is we only had private colposcopy, whereas now we had Barwon colposcopy service that was limited to healthcare card holders. And as all of you know, there's many people in the gap between healthcare card holders and being able to afford a private consult. So now we're very happy to be able to provide a colposcopy service to anybody and all comers. And they'll all be seen usually within 3 months, and HSILs within 4 weeks. And we have capacity to expand that colposcopy service as needed. So hopefully with the HPV screening program and vaccinations, colposcopy requirements will continue to stabilise and fall. We have subspecialty clinics, including, as you know from meeting Dr. Deb a few weeks or months ago, we have a perineal trauma clinic, which is the first in the state outside Melbourne. We've got an FDIU debrief clinic. We've now got the maternity trauma or maternity debrief clinic. So we're getting lots of obstetric patients out of our gynae clinic to run our gynae clinic more efficiently. And so basically in the last 2 years, we've gone from a 3-year wait basically to currently a 6-week wait. And outpatients wait list for urgent appointments is down to less than 4 weeks as needed. If it's particularly important, please call us or make it very clear in your referral. And we're down to 400 or less patients waiting first review gynae clinic. So if you build it, will they come? Basically, we've massively expanded the gynae service to the region because we feel that women's health, we want to serve the community and also serve you as primary providers or primary care physicians. So we want to be involved and help you out. Whereas it's been a much maligned service for many years prior to this, through no fault of anybody other than lack of resources. The trouble is, if we don't sustain these clinics, they will take them away from me. And when I lose my clinics, I also lose my theatre operating. If I lose my theatre operating, I'll lose my obstetric cover. So going forward, we intend to continue with subspecialty clinics in areas of interest. We hope to have a gynae fast track, a fertility service, a vulval derm clinic. We want to try and correspond with you better, so we want to eventually get to electronic letters, although I understand this has been promised for many years. It's a work in progress. So referral options, it's not very clear, but to make a referral to us, you actually use a surgical outpatients template, which I'm trying to get them to fix on our side. You can also fax. You can email for non-urgent queries. And if you ever need a clinically urgent question, this is the Gynae Reg phone, mobile phone, and this is my email. So I'm always happy to have questions or feedback or how we can help you better serve your patients and the community. But please get the word out there. Barwon colposcopy service is now free. We are not a pre-admission service only. We do all general gynae. And the only things we tend to send out nowadays is Gynae-Onc, which we often will work up here previously, and advanced urogynae. We now have essentially a local urogynaecologist coming once a week. We have 3 laparoscopic subspecialists. We've got many experienced general gynecologists. We do tapes, or we have people who do continence surgery. It's a really exciting department to be in, and we would like to help provide a service to the region. And so thank you for your time. I know it's late, but please publicise our service with your colleagues and your patients.
Just a couple of questions for you, Tony, from a GP. One of my gynae patients just got a letter back with a 12-month wait for an appointment. Was for endometrioma on ultrasound and subfertility.
Yeah, so the templates on is my camera still on?
Yes, it is. Yep.
So the templates will say up to 12 months, but in reality, it's about 6 weeks at the moment. Under promise, over deliver. I expect your patient will be seen in 3 months.
Thank you. And another question: how did this overdue improvement happen? Is this just a matter of funding?
A lot of work and effort and pre-planning, I suppose. It's a very long story, but essentially to get to this final destination in 2021, we started triaging your referrals by symptomatology back when I started around 2018-19. So this is the fruition and culmination of about 2-3 years worth of work. And a lot of that work has been Beck Murnane, my gynae outpatient clinic coordinator, and a lot of it has also been trying to improve our obstetric service. To improve our obstetric service, to get people into the public system, we need to have gynae operating. There was incredibly unfair watching from the sidelines that you get a smear, you're told you may get a cervical abnormality, which may be cancer, but you can't access colposcopies. It's incredibly unfair. People have to go to Melbourne for a vulval review. It's incredibly unfair that people with prolapse and urinary incontinence are waiting 3 years, not on the government books, and no one knows about them. So I think there was a great sense of injustice also driving all this, and I'm sure all of you out in primary care would have felt exactly the same frustrations. And so therefore, please, 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 now we've built it, please fill it. Otherwise, we will be back to the dark old days.
Thank you. We will finish up now. Thank you both for very informative webinar. I'll just leave you with a couple of comments. It's been great for heaps of my patients. So good. Thank you. That's from a GP to you, Tony. And thank you to you all. Very worthwhile webinar. That was for you, Payan and Tony. So thank you, everyone. We'll see you at our next one. Bye.
Bye.